But please remember, whenever there is a good pasture syndrome, there is formation of antibodies against the glomerular basement membrane and the basement membrane present in the lungs. So not only kidneys damage, but lungs is damaged as well. This can lead to which type of RPGN? Type 1 RPGN. So type 1 RPGN is usually because of the anti-glomerular basement membrane antibodies. Then the second type of RPGN. The second type of RPGN is an RPGN which is due to the formation of immune complexes. A typical example of immune complex formation and that causing damage to the kidney is a post-streptococcal glomerulonephritis. So in post-streptococcal glomerulonephritis, what happens is when the streptococcus enters into our body through the respiratory tract, antibodies against selective antigens of the streptococci, they bind with the antigen of the streptococci. The antigen antibody complexes will get deposited in the glomeruli and cause damage to the glomeruli. This type of immune complex damage leads to which type of RPGN? It can lead to type 2 RPGN. So type 2 RPGN is an RPGN which occurs because of immune complex damage. An example of this is post-streptococcal glomerulonephritis, or even an RPGN which is caused secondary to membranoproliferative glomerulonephritis. So whenever membranoproliferative glomerulonephritis or post-streptococcal glomerulonephritis leads to RPGN, it leads to which type of RPGN? It leads to type 2 RPGN. And the third type of RPGN is the type of RPGN in which there are hardly any immune complexes present. This type of an RPGN is known as posse-immune RPGN. Posse-immune means less, immune means immune complexes. Posse-immune glomerulonephritis, when it leads to RPGN, it causes which type of RPGN? It causes type 3 RPGN. This is the most common type of RPGN seen in children. I'll just write the same thing here so things are a little better. So RPGN, rapidly progressive glomerulonephritis, can be of three types: type 1 RPGN, type 2 RPGN, and type 3 RPGN. Type 1 RPGN usually follows anti-glomerular basement membrane antibodies, as occurs in the case of good pasture syndrome. As occurs in the case of good pasture syndrome. Type 2 RPGN usually occurs secondary to immune complexes, as occurs in the case of post-streptococcal glomerulonephritis or membranoproliferative glomerulonephritis. So when post-streptococcal glomerulonephritis or membranoproliferative glomerulonephritis leads to RPGN, rapidly progressive glomerulonephritis, it causes which type of RPGN? It causes type 2 RPGN. And the third type of RPGN, the third type is usually an RPGN follows those type of glomerulonephritis in which the immune complexes are minimum. In type 2, immune complexes are the maximum, they are causing the maximum damage. In type 3, immune complexes are minimum. These type of very rare glomerulonephritis are known as posse-immune glomerulonephritis. Please don't get confused. These type of glomerulonephritis are very rare, but among the causes of RPGN, they are the one which are most likely known to cause RPGN. So the most likely cause of an RPGN is these causes: posse-immune glomerulonephritis. They are the most common causes of RPGN. Posse means less, immune means immune complexes. Most of them are actually disorders which are vasculitis disorders, which are associated with a group of antibodies which is known as anti-neutrophilic cytoplasmic antibody, ANCA. What is the full form? anti-neutrophilic cytoplasmic antibodies. So these type of glomerulonephritis, which usually occur secondary to vasculitis, are known as posse-immune glomerulonephritis. I can give you an example. Examples of these are Wegener's granulomatosis. You must have heard of this name, Wegener's granulomatosis. It's a type of vasculitis of childhood, or even a Churg-Strauss syndrome. So these were old names. They have been changed to new names, but for your examination purposes, just remember them. So RPGN can be of three types: type 1 RPGN, type 2 RPGN, and type 3 RPGN. Type 1 RPGN, as I told you, usually follows anti-glomerular basement membrane antibodies. Type 2 RPGN is known to follow immune complex glomerulonephritis, such as post-streptococcal glomerulonephritis or membranoproliferative glomerulonephritis. It is the type 3 glomerulonephritis, it's the type 3 RPGN It is the type 3 RPGN, which is the most common and usually results because of posse-immune glomerulonephritis. Now, what is meant by posse-immune glomerulonephritis? Posse means less, immune means immune complexes. So, very little immune complexes in this type of glomerulonephritis. They usually are groups of vasculitis which are associated with anti-neutrophilic cytoplasmic antibodies. They are associated with anti-neutrophilic cytoplasmic antibodies. Examples of these disorders are Wegener's granulomatosis and Churg-Strauss syndrome. So type 1 RPGN, usually occurring because of anti-glomerular basement membrane antibodies. Type 2 RPGN, usually occurring because of immune complex disorders. And type 3 RPGN, usually occurring because of posse-immune glomerulonephritis. So I hope you have all written this. RPGNs, because these are the disorders which are known to rapidly progress. So what was the criteria I told you for RPGN? I told you the criteria for rapid progressive glomerulonephritis is rapid deterioration in renal functions, including 50% decline in renal functions in 3 months, and the presence of crescents in minimum 50% glomerulus. So these are very dangerous disorders because there is rapid decline in renal functions. So they should be treated aggressively. So what is the treatment of rapid progressive glomerulonephritis? It can be any one of these three: type 1 RPGN, type 2 RPGN, and type 3 RPGN. All of them are usually treated by giving a combination of corticosteroids along with cyclophosphamide. So how are these disorders treated? They are all treated by combination of corticosteroids along with cyclophosphamide. They are treated with a combination of corticosteroids along with cyclophosphamide. So I hope you have written everything that I was trying to tell you. With this, we come to the last group of disorders in nephrology. which is nephrotic syndrome. So this is the last group of disorders that we'll do in nephrology, which is nephrotic syndrome. Now, nephrotic syndrome is a disorder which is associated with selective proteinuria in children. Nephrotic syndrome is a disorder which is associated with selective proteinuria in children. Now, both these disorders are disorders which are associated with inflammation of glomerulus, glomerulonephritis also, nephrotic syndrome also. Please try to understand. Both these disorders are disorders which are associated with inflammation of the glomerulus. But when there is primarily hematuria, then this condition is known as glomerulonephritis, and when there is primarily proteinuria, then this condition is known as nephrotic syndrome. How do you define pathological proteinuria? Please understand, some amount of proteinuria normally occurs in the urine. A pathological proteinuria will be defined as a urine protein output which is more than 3.5 grams of proteins per day. Otherwise, some amount of protein normally is passed per day. But whenever it is more than 3.5 grams of protein per day in the urine, we call this as pathological proteinuria, and the condition is known as nephrotic syndrome. A basic difference that we all know between nephrotic syndrome of childhood and nephrotic syndrome in adults is that in adults, nephrotic syndrome usually is a non-selective proteinuria. Please pay attention. Nephrotic syndrome in adults is a non-selective proteinuria. That means low molecular weight proteins are also lost in urine, high molecular weight proteins are also lost in urine. But in the case of children, we normally have a selective proteinuria. That means only low molecular weight proteins are lost in urine, not the high molecular weight proteins. Only low molecular weight proteins are lost in urine. So nephrotic syndrome in children is characterized by selective proteinuria. That is why I've kept it in the heading. Just see the heading. Heading says nephrotic syndrome, selective proteinuria. Why do we say selective proteinuria? Only low molecular weight proteins are lost in the urine, not the high molecular weight proteins. Now, what are the features of nephrotic syndrome in children? So the first feature of nephrotic syndrome in children is low levels of albumin. Reason is albumin, being a very low molecular weight protein, is being lost in the urine. So that is why there is hypoalbuminemia or low levels of albumin. And this low levels of albumin, what does it do? Because it decreases the oncotic pressure inside the vessels. So that is why it contributes to the development of edema. So edema, which is the characteristic feature of nephrotic syndrome, primarily is caused by low albumin levels. The second important feature of nephrotic syndrome in children is high cholesterol levels. This is primarily because of increased synthesis, increased lipoprotein synthesis by the liver. So increased lipoprotein synthesis by the liver will lead to the development of high levels of cholesterol. So when proteins are lost, what does liver try to do? It tries to increase the lipoprotein synthesis, which is known to be responsible for high cholesterol. Then there is increased risk of thrombosis in these children, increased thrombotic risk, which occurs in nephrotic syndrome. That is why dehydration should always be prevented in nephrotic syndrome, because if a child of nephrotic syndrome becomes dehydrated, the child is likely to have an increased risk of thrombosis. And finally, immunoglobulin loss of immunoglobulins. Is responsible for infections that occur in nephrotic syndrome. So nephrotic syndrome in children is characterized by low levels of albumin, high levels of cholesterol, increased risk of thrombosis, and high infection levels. Low levels of albumin, high levels of cholesterol, increased risk of thrombosis and infections. And what are the infections due to? Infections primarily are because of loss of immunoglobulins. The primary infection that is known to cause death in these children, most common infection which causes death, is peritonitis. So which is the most common infection which occurs in nephrotic syndrome and is known to cause death? It is bacterial peritonitis or a subacute bacterial peritonitis. So either a bacterial peritonitis or a subacute bacterial peritonitis is the main cause of death which occurs in nephrotic syndrome, the main infection that causes death in nephrotic syndrome. So hypoalbuminemia, low albumin, high cholesterol, increased risk of thrombosis and infections. These are the primary features of nephrotic syndrome. Now, in children, most cases of nephrotic syndrome, almost 85% cases, as you can see on your screen, are caused by a minimal change disease. Almost 85% cases of nephrotic syndrome in children are caused by a disease known as minimal change disease or lipoid nephrosis. Now here, the findings on the glomerulus under histology, they will be minimum. That is why there is no need to do a renal biopsy whenever the nephrotic syndrome occurs, usually in children. Reason being very simple, that the majority of cases are caused by a minimal change disease. And minimal change disease, if you take the biopsy findings of these children and see them under the microscope, because the disease is known as minimal change disease, there will be hardly any findings. So routinely, biopsy is not recommended in children who have nephrotic syndrome. Yes, when nephrotic syndrome occurs in adolescence, that is one of the indication for doing a renal biopsy, because the most common cause of nephrotic syndrome in adolescence and probably also in adults is a disorder known as focal segmental glomerulosclerosis. So don't get confused. Overall in childhood, which is the most common cause of nephrotic syndrome, it is minimal change disease. But if nephrotic syndrome for the first time occurs in an adolescent, the most likely cause of this nephrotic syndrome is a focal segmental glomerulosclerosis, which can be identified only by its renal biopsy findings. That is why when nephrotic syndrome occurs in adolescents, it is important to do a renal biopsy to confirm this is a case of focal segmental glomerulosclerosis. And only about 5% cases of nephrotic syndrome in children are caused either by membranous glomerulonephritis, what is MGN, membranous glomerulonephritis, or they are caused by membranoproliferative glomerulonephritis. So what is the most common cause of nephrotic syndrome in children? It is minimal change disease. It is also known as lipoid nephrosis. 85% cases of nephrotic syndrome in children are caused by this condition. About 10% cases of nephrotic syndrome are caused by focal segmental glomerulonephrosis. But whatever cases are caused by focal segmental glomerulosclerosis, most of those cases of adolescents. That is why I'm again and again saying nephrotic syndrome in adolescents, the most common cause is likely to be a focal segmental glomerulosclerosis. So which is the most common cause of nephrotic syndrome in children? Minimal change disease. But which is the most common cause of nephrotic syndrome in adolescents? It is focal segmental glomerulosclerosis. So they are important. And the remaining 5% cases of nephrotic syndrome in children are caused by membranous glomerulonephritis, MGN, or membranoproliferative glomerulonephritis, MPGN. So this is very important and you should remember which is the most common cause of nephrotic syndrome. In children, it is minimal change disease. And which is the most common cause of nephrotic syndrome in adolescents? It is focal, segmental, glomerulosclerosis. In short, it is also called as FSGS. So which is the most common cause of nephrotic syndrome in children? It is minimal change disease. But which is the most common cause of nephrotic syndrome in adolescents? It is focal segmental glomerulosclerosis. The treatment of choice of nephrotic syndrome. The treatment of choice of nephrotic syndrome. Is usually corticosteroids. What is the treatment of choice? It is corticosteroids. So prednisolone is the drug of choice, and a total of 12 weeks therapy is usually recommended. So out of this, first 6 weeks should be daily prednisolone, and then next 6 weeks should be alternate day prednisolone. So a total 12 weeks of corticosteroid therapy is usually recommended to treat nephrotic syndrome. The first 6 weeks should be giving corticosteroids daily, prednisolone daily, and this should be followed by prednisolone, which should be given alternate day. So that is probably a total of 12 weeks treatment that is known to result in the resolution of proteinuria in the maximum number of cases. I think we mentioned it here also. Okay, so I have not mentioned it here, but anyway, so total of 12 weeks therapy is usually recommended. So total 12 weeks therapy is usually recommended. 6 weeks of daily prednisolone and 6 weeks of alternative prednisolone. There are two subset of nephrotic syndrome cases which require special treatment. And which are these two subset of nephrotic syndrome cases which require special treatment? One are cases where the child is having a steroid dependent nephrotic syndrome, and both of them have been asked in FMG. One is steroid dependent nephrotic syndrome, and the second is a case of a steroid resistant nephrotic syndrome. Whenever you have steroid dependent nephrotic syndrome and steroid resistant nephrotic syndrome, then only corticosteroids will not work. In fact, in steroid resistant cases, the corticosteroids do not work because the child is resistant to corticosteroids. So in those cases, the drug of choice should be known to you. In steroid dependent nephrotic syndrome, the drug of choice usually is levamisole. And if levamisole is not one of your choices, then the other drug is cyclophosphamide. So what is the drug of choice for a steroid-dependent nephrotic syndrome? It is levamisole, which is first-line therapy. But if levamisole is not one of the choices that is given, then the next therapy that you should recommend is a cyclophosphamide. For a steroid-resistant nephrotic syndrome, cyclosporin is the drug of choice. So I'll repeat again. What is the drug of choice for the treatment of nephrotic syndrome in general? The drug of choice for the treatment of nephrotic syndrome in general is prednisolone, corticosteroids. Usually, how long should corticosteroids be given in these cases? Prednisolone, for example, is given for a total of 12 weeks. So 2 milligrams per kg per day, you may not require to know the dose. 2 milligrams per kg per day should be given for the first 6 weeks, followed by 1.5 milligrams per kg alternate day, which should be given for the next 6 weeks. So if you want, I can write the dose. 2 milligrams per kg per day should be given for the first 6 weeks, followed by 1.5 milligrams per kg alternate day should be given for the next 6 weeks. So total how long? Total 12 weeks of treatment is recommended. However, there are a subset of cases of nephrotic syndrome which are either totally dependent on corticosteroids or they are resistant to corticosteroids. So these two cannot be managed by corticosteroids alone. So what is a drug of choice for a steroid dependent nephrotic syndrome, and what is a drug of choice for a steroid resistant nephrotic syndrome? So the drug of choice for a steroid-dependent nephrotic syndrome is levamisole or cyclophosphamide, but the drug of choice for a steroid-resistant nephrotic syndrome is cyclosporin. Right? So I'll just repeat once again so that we revise nephrotic syndrome. I said both glomerulonephritis and nephrotic syndrome are type of inflammation of the glomerulus. When inflammation of the glomerulus primarily leads to hematuria, we call this disorder as glomerulonephritis. When inflammation of the glomerulus leads primarily to proteinuria, we call this disorder as a case of nephrotic syndrome. Nephrotic syndrome, as the name suggests, is primarily pathological proteinuria, and pathological proteinuria usually is defined by a select way. And how do we define pathological proteinuria? As I told you, it is urine protein excretion more than 3.5 grams of protein per day. Now, children who have nephrotic syndrome are known to have low levels of albumin because of hypoalbuminemia. They have high levels of cholesterol, which is because of increased lipoprotein synthesis by the liver. Then these children in addition have high risk of thrombosis, and they have a high risk of infections because of loss of immunoglobulins. The infection that is most commonly known to cause death in a child of nephrotic syndrome is either a bacterial peritonitis or a subacute bacterial peritonitis. In children, the most common cause of nephrotic syndrome is minimal change disease, also called as lipoid nephrosis, seen in almost 85% cases. 10% causes of nephrotic syndrome are focal segmental glomerulosclerosis, and about 5% cases are caused by membranous or membranoproliferative glomerulonephritis. Please don't get confused. The most common cause of nephrotic syndrome in children is a minimal change disease, but the most common cause of nephrotic syndrome in adolescents is focal segmental glomerulosclerosis. So when the question comes in the exam, be very careful in answering the question after completely reading the question. Most common nephrotic syndrome in children is minimal change disease. Most common nephrotic syndrome in adolescents is focal segmental glomerulosclerosis. The treatment is usually corticosteroids. As I told you, for how long corticosteroids should be given? 12 weeks. 2 milligrams per kg per day for the first 6 weeks of prednisolone, followed by 1.5 milligrams per kg alternate day for the next 6 weeks. Majority of cases responds to corticosteroids. However, there are cases which are steroid dependent and steroid resistant cases of nephrotic syndrome. A steroid dependent case of nephrotic syndrome is totally dependent on steroids. A steroid resistant case of nephrotic syndrome is resistant to the steroids. These require separate treatment. In a steroid dependent case of nephrotic syndrome, apart from corticosteroids alternate doses, tapering doses, the drug of choice will be levomazole. And if levomazole is not one of the choices, then the answer will be cyclophosphamide. But the drug of choice in a steroid resistant case is cyclosporine. Right? Please check Ghai also. I think these have been taken from Ghai only, OP Ghai only. But just check once in OP Ghai also, what are the drugs of choice. They have given the drugs of choice in OP Ghai for steroid dependent cases and steroid resistant cases. And please cross check them. These are other drugs of choice in OP Ghai also. I think these are the drug of choice. They have given a number of drugs in the list, but for you, you have to remember the main drug that is used. So levomazole followed by cyclophosphamide in corticosteroids in the order of preference. And in steroid resistant cases, it is cyclosporine. Just a word about congenital nephrotic syndrome. Now, congenital nephrotic syndrome is very much similar to a nephrotic syndrome. Only thing is that this is the nephrotic syndrome that develops at birth or within 3 months after birth. I think within 3 months of birth. So either it develops at birth or develops within 3 months of birth. Most of the cases of congenital nephrotic syndrome are because of mutation in certain genes. There is 2 important types of nephrotic syndrome that you should remember. The Finnish type of nephrotic syndrome, which is a type of congenital nephrotic syndrome, usually occurs because of mutation in which protein? It usually occurs because of mutation in the NPHS1 gene, which codes for nephrin, and the steroid resistant nephrotic syndrome occurs because of mutation in the NPHS2 gene, which encodes for codeine. So there should be no confusion. Mutation in NPHS1 gene, which encodes for nephrin, is known to result in the most common type of congenital nephrotic syndrome, which is called as Finnish type of nephrotic syndrome. But mutation in NPHS2 gene, which codes for codeine, is known to result in a steroid resistant nephrotic syndrome. So mutation in NPHS1 gene, which codes for nephrin, will result in Finnish type of nephrotic syndrome, and mutation in NPHS2 gene, which codes for codeine, will result in a steroid resistant nephrotic syndrome. So with this, we finish up pediatric renal disorders. I'll just so let us revise now pediatric nephrology and whatever we did in pediatric nephrology. So I started my nephrology class by telling you the causes of abdominal mass in newborns. I told you almost 60% of abdominal masses in newborns are known to arise from the kidneys. The most common cause of abdominal mass in newborns is hydronephrosis. The second most common cause of abdominal mass is multicystic dysplastic kidney. So this should be the answer if hydronephrosis is not one of the choices. And another important cause of abdominal mass in newborns is the tumor of the kidney, which is known as mesoblastic nephroma. So which is the most common tumor of the kidney in a child? In a child, it is Wilms tumor, but which is the most common tumor of the kidney in a newborn? It is not Wilms tumor, it is mesoblastic nephroma. Then we talked about congenital cystic disorders of the kidney, where I talked about multicystic dysplastic kidney, polycystic kidney disease, and a medullary sponge kidney. Most common congenital cystic disorder of the kidney is multicystic dysplastic kidney, which usually is not hereditary, it is sporadic. But polycystic kidney disease is familial, runs in families, and usually is an autosomal recessive inheritance. So infantile polycystic kidney disease is autosomal recessive polycystic kidney disease. While polycystic kidney disease affects both the kidneys, multicystic dysplastic kidney affects one kidney. Polycystic kidney disease, the cyst arrangement is usually in a radial fashion. Multicystic dysplastic kidney, cysts are in a random fashion, which is also known on an ultrasound as a soap bubble appearance or a bunch of grapes appearance. Then medullary sponge kidney, only one thing to remember, the intravenous pyelography shows a paintbrush appearance or a bouquet of flower appearance. Having said this, now we come to urinary tract. Then I came to Porter's syndrome. Porter's syndrome, I told you, associated with bilateral renal agenesis. Which were the features of Porter's syndrome? P-O-T-T-E-R. So P stands for pulmonary hypoplasia, O stands for oligohydramnios, T stands for twisted skin or wrinkles on the skin. Next T stands for twisted fascias or abnormal fascias. E stands for extremity defects, and R stands for renal agenesis. So Porter's syndrome associated usually with bilateral renal agenesis. Then I talked about urinary tract infection in children. I told you the cause of recurrent UTI in children is a vesico-ureteric reflux. And to identify VUR and damage to the kidneys because of VUR, we need 3 investigations: ultrasound of the kidneys, then micturating cystourethrogram, and the DMSA scan, which is the gold standard investigation to identify a vesico-ureteric reflux. It is micturating cystourethrogram, also known as a DMSA, also known as a VCUG, voiding cystourethrogram. So I told you, according to the age of the child, when the child has a first UTI, you identify which is the investigations I will do. So if a child is less than 1 year and first UTI occurs, in these cases, all the 3 investigations need to be done. If the child is between 1 to 5 years and has a first UTI, an ultrasound and a DMSA scan is done first, not an MCU. If an ultrasound and DMSA are normal, then nothing to be done. If an ultrasound and DMSA are abnormal, results are abnormal, then you do an MCU. And if the child is more than 5 years and then had the first UTI, only an ultrasound needs to be done first. Results normal, nothing to be done. Results abnormal, then you perform an MCU and a DMSA scan. So this was about identifying urinary tract infections. Radionuclide scans, I told you, DTPA scan, DMSA scan, and MAC3 scan. The DMSA scan is usually for structural abnormalities in the kidney, while the DTPA scan and MAC3 scan are for functional abnormalities in the kidney. What functional abnormalities the DTPA scan look for? Abnormalities in glomerular filtration rate. And what abnormality does the MAC3 scan look for? Abnormalities in the renal plasma flow. Then I told vesico-ureteric reflux can be a primary vesico-ureteric reflux and a secondary vesico-ureteric reflux. VUR is more common in females compared to males. And normally mode of inheritance of a vesico-ureteric reflux is autosomal dominant mode of inheritance. The most common cause of vesico-ureteric reflux in male infants is posterior urethral valve, where there is an obstruction at the level of prostatic urethra. What is the screening method for a posterior urethral valve? It is a fetal ultrasound showing a keyhole sign. And what is the confirmation method? After the child is born, you have to perform a micturating cystourethrogram. Then another important cause of vesico-ureteric reflux, particularly in female infants, is a ureterocele. The part of the ureter which enters into the bladder is dilated, the lower part of the ureter. So ultrasound showing a keyhole sign, posterior urethral valve. Ultrasound showing a cyst within a cyst appearance, a ureterocele. And an ultrasound showing a bunch of grape appearance is usually a multicystic dysplastic kidney. IVP showing a paintbrush appearance or a bouquet of flower appearance, medullary sponge kidney, and IVP showing a cobra head or adder head appearance, ureterocele. Then I told you, majority of vesicular refluxes, they are graded from grade 1 to grade 5. Majority of them will resolve on their own in 3 to 4 hours time. So just put the child on antibiotic prophylaxis, which is the preferred drug, especially in very young children, less than 6 months, it is Ceflexin. Which are the indications for performing a surgery? Children who are more than 1 year of age and have a high grade reflux, or children who have a UTI while they are on antibiotic prophylaxis. Then I did about glomerulonephritis, where I talked about the types of glomerulonephritis, and I talked about the 3 types of glomerulonephritis associated with low C3 levels. Post-streptococcal glomerulonephritis, IgA nephropathy, and I talked about lupus nephritis. Alport syndrome is a triad of glomerulonephritis, sensorineural deafness, and changes in the eye. And what is the change in the eye which is seen in Alport syndrome? It is anterior lenticonus. Posterior lenticonus seen in Lowe syndrome. What is the main cause of Alport syndrome? It is defect in the alpha chain of collagen. So basically collagen which is getting deposited in different parts of the body. So different parts of the body has collagen. So collagen is an important component of the basement membrane of the kidneys also. So whenever this collagen is defective, there will be filtration of RBCs or proteins through the urine and will result in either the development of hematuria or the development of proteinuria. So defect in alpha 5 chain of collagen will result in Alport syndrome. Then I talked about IgA nephropathy and its differences with post-streptococcal glomerulonephritis. IgA nephropathy, chronic glomerulonephritis, post-streptococcal acute glomerulonephritis. IgA nephropathy usually in 10 to 20 year age group, post-streptococcal 5 to 12 years age group. IgA nephropathy, hematuria usually 1 to 3 days of throat infection, post-streptococcal 1 to 3 weeks of a throat infection. IgA nephropathy recurrences are common, post-streptococcal recurrences are rare. IgA nephropathy C3 levels are usually normal and post-streptococcal C3 levels are very low or low. IgA nephropathy, the biopsy findings are mesangial proliferation IgA deposits, post-streptococcal diffuse endocapillary proliferation. And the renal biopsy findings of IgA nephropathy also seen in cases of Hinault-Schwann purpura. The treatment of choice of IgA nephropathy is corticosteroids and ACE inhibitors, while the treatment in the case of PSGN is symptomatic management. Then how many children go on to develop glomerulonephritis in Hinault-Schwann purpura? 50% cases. And within what time of the onset of illness will hematuria occur? If hematuria has to occur, it will occur within 3 months of the onset of illness. Hinault-Schwann purpura is the most common vasculitis of childhood, associated with symptoms such as abdominal pain, arthralgias, and rashes. 50% children may go on to develop glomerulonephritis. Then I talked about post-streptococcal glomerulonephritis. Sorry, I talked about rapid progressive glomerulonephritis. I told you type 1 RPGN usually follows anti-glomerular basement membrane antibodies. Type 2 RPGN usually follows immune complex induced damage, and type 3 RPGN usually follows pauci-immune glomerulonephritis, the vasculitis associated with anti-neutrophilic cytoplasmic antibodies. Then I talked about nephrotic syndrome, and in nephrotic syndrome, I talked about the features of the nephrotic syndrome, pathological proteinuria, which is more than 3.5 grams per day, and the fact that there is selective proteinuria in nephrotic syndrome in children. Only low molecular weight proteins are lost, not the high molecular weight proteins. The most common nephrotic syndrome in children, most common cause of nephrotic syndrome in children is minimal chain disease, but the most common cause of nephrotic syndrome in adolescents is focal segmental glomerulosclerosis. Treatment of nephrotic syndrome in children is usually corticosteroids, prednisolone, given 6 weeks daily, 6 weeks alternating. Drug of choice for steroid dependent case of nephrotic syndrome, drug of choice is cyclophosphamide or levamisole. Levamisole should be taken as the first preference, then cyclophosphamide. And drug of choice for a steroid resistant nephrotic syndrome is cyclosporine. Then we talked about congenital nephrotic syndrome, and I talked about congenital nephrotic syndrome. Finnish type of nephrotic syndrome usually occurs because of mutation in NPHS1 gene, and steroid resistant nephrotic syndrome usually due to mutation of NPHS2 gene. So with this, we finish up renal disorders, which is chapter number 5. I hope, again, as with the previous chapters, you have understood renal disorders very well. With this, we finish up 85 to 90% of pediatrics. Now only two very small chapters left. One is respiratory disorders and one is gastrointestinal disorders, which we'll do tomorrow starting from 10:30 a.m. in the morning. So I hope the class today was good. You have understood the things well. If you have any questions, you can ask me in the next 5 minutes, and then we'll restart tomorrow morning at 10:30. Thank you very much.